thing in radiation practice. And always we do from the morning to evening, we do pushing the target forward and pushing the OR backward. It is our daily business. But keeping this business at optimum, we have to know the proper guidelines about the proper target delineations and for tissue and OR. So target contouring errors generate systematic errors which no level of image guidance will eliminate. So target delineation is very important thing, what to contour and what not to contour. Slight error, it causes systematic errors, and which no level of image guidance you do, that is not going to help you. So as you know, reduction in PTV by custom evaluation, respiratory management, image guidance, we can decrease from the PTV to small PTV, and more smaller PTV is the lesser dose to the tissue, ORs, and will have optimum results. So if any structures, any contouring guidelines, we have a delineation of OR and targets. So in the settings of post MRM, either with chest wall or sometimes chest wall plus nodes, in BCS, breast plus nodes, and boost. These are the two settings we come across. In target, what are the things? Mostly the chest wall, breast, nodes, level 1, 2, 3, IMN, and SCF, and sometimes boost cavity if you are planning for the BCS. OR mostly both lungs, heart, coronary vessels, brachial plexus, contralateral breast, and if you are treating the esophagus, sometimes thyroid and esophagus or post-cricoidea come to your as a OR. Guidelines are many guidelines. It is published URTC, RTOG, TRO guidelines, Red Camp guidelines, fast forward guidelines. So these guidelines are there. Always we fumble which guidelines you take, and controversies existing. Boundary guidelines, either you go through the musculoskeletal guidelines or vascular guidelines. So the most followed guidelines in the radiation practice is the ISTRO guideline. Apart from that, these are the various boundaries of the things we will go later. Then we have a RTOG guidelines where the large volume is very large, and your lung dose, heart dose will be more. So another guideline is the fast forward guideline. I will show you later how to deal with the fast forward guidelines. Then these are the planning text for the fast forward guidelines. So that is the host, whole, breast, chest wall, and boost. And this is the fast forward guidelines. Another is the red comp guidelines. You can easily go get from the e-contour site or all sites. These are the red comp consortium. Another guideline is pro-cup vascular guidelines. You can this is also published in Green Journal 2014. So these are the various guidelines. I will come later. You can go through these things later part. What are the normal structures we should understand? We should know before contouring the starts contouring. In the proctoralis minor, major, latissimus dorsi, sternocleidomastoid muscles, calinus, subscapularis, centrocostal muscles we to identify properly. In basals, you have to contour the brachiocephalic, subclavian, thoracic, internal mammary, internal jugular vein. Cartilages and bones, you have to know where are the ribs, counting the ribs from the first to mainly 10th and 11th ribs. Clavicle, sternum, carotid, cricoid, and scapula, these structures you have to identify. Why there is a need of HRT, when which conditions, like all patients who received NACT or NAHT hormonal therapy, other MRM cases where the indications are there, all BCS cases, they should receive the radiation. Axillary nodes, when there is a sentinel node biopsy, only when they're N positive. IMN, all NACT patients and medial inner quadrant tumors and then high axillary burden, you can go for the IMN irradiation. Any mostly older supraclavicular guidelines to treat supraclavicular area, even there is 4 nodes are positive, but we are now treating any node positive with treating the ACF. Before going to the direct guidelines, direct contouring, we should understand the vasculature system of the thorax. So as you know, these are the arch of aorta. As you know, these are arch of aorta. It is a 3 branches. One is the right brachiocephalic, carotid, and subclavian. Left carotid and subclavian. Right brachiocephalic gives rise to 2 branches: right common carotid and left subclavian. Right subclavian. So if you want to remember BCS, you can remember. So apart from that, you can see the right common carotid, right subclavian, brachiocephalic. This is brachiocephalic, and two coronary arteries from the root of the aorta. They are the various. Why it is very important is the vascular guidelines is. Vascular guidelines, it is needed to understand the vascular structure. I will come later. So as you know, the superior vena cava, inferior vena cava, they drain to the right atrium. From the right atrium to right ventricle, then pulmonary artery, the pulmonary trunk. Then from the pulmonary veins, it goes to the left atrium, then left ventricle, and then goes to the arch of aorta. So these are the vasculatures. Venous structures: left subclavian, left internal jugular, left from the left brachiocephalic vein, right internal jugular, right subclavian comments the right brachiocephalic, and here azygous vein in right, hemizygous vein in the left. They combine to the superior vena cava. So this is the venous system of the thorax. As you know, as I told, so this is the arch of aorta. It is 3 branches: right brachiocephalic, left common carotid, and left subclavian. And it is ascending aorta and descending aorta. So, and there are main 2 arteries, coronary arteries. You know, this is the aorta, root of the aorta. There is 2 branches. One is the right coronary artery and left coronary artery. And this left coronary artery, left circumflex, and left anterior descending. I will come later. So this is the thing where the subclavian arteries. You can see this is the subclavian arteries. Then the right subclavian artery dumps into the brachiocephalic artery. So the the brachiocephalic artery gives branches to the left, right common carotid and right brachiocephalic. So this is the thing you have to remember. Then the arch of aorta, if you come down, arch of aorta, 3 branches as I showed. This is the right brachiocephalic, left common carotid, and left subclavian. So these 3 aorta branches you have to see. This is this happens when the contrast injected into the vein of the subclavian vein. Then you can see, so these 2 branches you can see, arch of aorta. This is ascending aorta. This is the descending aorta, and this is arch of aorta. And this is the left brachiocephalic vein drains in, drains to the superior vena cava. Then this is the aortic arch. This is the aortic arch. This is the aortic arch. This is the superior vena cava. This is the superior vena cava here. Then this is the azygous vein. The azygous vein drains to the superior vena cava. Then this is the carina. This is the carina. Then what is the this is the pulmonary trunk, left pulmonary artery. This is the left pulmonary artery. Then this is the pulmonary trunk. Then as ascending aorta, descending aorta. This is the left atrium. This is the left atrium. Then left circumflex. You can see this is the left main coronary artery. This is the left main coronary artery. This is the left coronary branches to give to the circumflex, that is the circular, and left anterior descending 2 branches. You can see them. You can see these 2 branches, the circumflex artery and left anterior descending. Then if you see the position of the heart chambers is not like straightforward. The right side, left side is the right ventricle and left ventricle. Right side is the right atrium and left atrium. Left atrium is posterior, right atrium is the anterior. So you can see the aortic seminal valve, aortic root of the aorta. You can see this aorta is going, aorta mainly arising from the left ventricle. So you can see this aorta, this left ventricle. This is the left ventricle that light red the thing area, and this is the interventricular septum, and this is the right right ventricle. Posterior is the left atrium, and if you go down, this is the thick muscular wall of the heart. So you can, this is the pericardial sac. Remember, when you are contouring the heart, you should not include the pericardium. And pericardium, if you include the pericardium, your heart dose definitely shows falsely increased dose. So you should not contour the pericardium when you're contouring the heart. So this is the all structures. So if you go to the vasculature based contouring, you have to remember two arteries. Medial mammary branches of internal thoracic artery. This is the medial mammary branch of the internal thoracic artery. These are the mostly medial branch, medial boundary of the any breast cancer contouring of the breast or MRM. And this is the lateral thoracic artery. So this lateral, you have to remember these two arteries. And when you are doing the simulation for the breast cancer, you can take this two contouring, you can take the contrast area and two contours, you have to contour these two, so you have to remember these two boundaries. So these are the mainly vasculature structures I showed in this these above slices. Now we will show the thoracic muscles. So as you know, there are two muscles which is mostly important and the main play in our daily practice. One is the anteriorly the pectoralis major, which protects the pectoralis minor. So this is the pectoralis minor and this is the pectoralis major. Apart from that, there are intercostal muscles, internal intercostal, external intercostal muscles. Apart from that, this is the subscapularis. This is the subscapularis. This is the lateral to the serratus anterior. This is the serratus anterior. This is scapula. And this is the latissimus dorsi. This is the latissimus dorsi. And this is the infraspinatus muscle of the scapula. Now, you can remember again, above the spine, it is supraspinatus muscle, biceps tendon here, humeral head here, deltoid, infraspinatus muscle. So in the most of the things, axillary boundary, you can see this pectoralis major and minor muscles, serratus anterior and thoracic wall, humeral head, and posterior body, the scapularis, teres major, and latissimus will come later. So in axilla, if you see, there are three groups, main the lymph node, three group of lymph nodes along the axillary vein and artery, and it divides into level 1, level 2, and level 3. And if you see, the two muscles are there, pectoralis major and major pectoralis minor. So lateral to the pectoralis minor muscle is the node groups are called level 1. Posterior to the pectoralis minor is level 2, and medial to the pectoralis minor is the level 3. So these are the various groups of lymph nodes you have to remember when you are contouring the nodal contouring in the breast cancer. So this is the axilla area. I will show you again. So this is the levels of axillary node. Level 1 located laterally or below the lower margin of the pectoralis major. Level 2 is located deeply to the pectoralis minor. Level 3, medial or superior to the pectoralis minor is the level 3. So this is the again in the anatomical landmark used for the labeling of the axillary lymph nodes is the pectoralis minor. Remember, lateral to the pectoralis minor is the level 1. Posterior to the axillary lymph node, pectoralis minor is the level 2. Medially to the pectoralis minor is the level 3 group of lymph nodes, roughly you can remember. So this is the level 1, you can see here, level 2 and level 3. So these are the various group of lymph nodes you can remember. This is level 1. This is the level 2, how it is there here. So this is level 2, and this is level 1, this is level 2, and this is the level 3 group of enlarged group of lymph nodes. So sometimes we fumble whether treat the axillary lymph nodes or not. So as a rule, if you are adequate 12 group of lymph nodes at least dissected during the MRM or BCS, you no need to treat the axilla as such. Surgery is sufficient. But when you have done the sentinel node biopsy, and node is negative, no need to treat the axilla. axillary radiation, but nodes are positive as a grossly we can treat. So suppose your axillary US before neoadjuvant chemotherapy, no suspicious. Axillary ultrasound after NSC, not suspicious, you do sentinel lymph node biopsy. But if it is a suspicious, then you go for lymphadenectomy. So if before NSCT, if it is suspicious, if it is a biopsy is negative, go for axillary ultrasound after NSCT. Not suspicious, do even in not suspicious, go for the axillary dissection. If it is early lesion, palpable axillary node, axillary ultrasound, negative, do sentinel lymph node biopsy. Axillary ultrasound, do FNSC. If there is a positivity, negative, go for sentinel lymph node biopsy. But if there is axillary positive, go for the lymphadenectomy. No palpable, do axillary ultrasound. If it is axillary ultrasound is negative, do sentinel lymph node biopsy. If it is FNSC is positive, then go for the axillary tumor lymphadenectomy dissection. If it is negative, you can go for the sentinel lymph node biopsy. So there are two muscles, as I told, pectoralis major muscle and pectoralis minor muscle. These are two muscles you can see here. This is the origin of coracoid process of the scapula, where the pectoralis minor muscle originates. This is the pectoralis major muscle. You can go down, you can see how this pectoralis minor muscle, how it became the horizontal here. You can see this is the pectoralis major, this is the minor. Again, go down, go down, go down. So pectoral around third and fourth rib, the pectoral minor muscle disappears or insert to the ribs. Then this pectoralis major muscle. So this is the pectoralis major and minor muscle. Then, as you know, this is the surgical 3 levels I have already explained. So how to control the axillary group of lymph nodes? Contour the fat space around the muscle. Very simple way is the contour the fat space around the muscles. But what are the superior boundary, inferior boundary, what is the caudal boundary, cranial boundary, lateral boundary, medial boundary? We'll discuss one by one. But remember, your aim is to contour the fat space around the muscles and include the vessels. So as you know, as I told, this is the axillary group of lymph nodes. So let's discuss about the level 1 first. So there are many guidelines: ISTRO guideline, RTOG guideline, RTOG REDCOM guideline, and DRAW guideline. Everybody has given almost similar group of margin boundaries, but somebody has taken the vessels, somebody has taken the muscles. But how to do that? How to remember? So this is the best if you contour the RTOG guidelines and ISTRO guidelines. So this is the RTOG guidelines, always volume is larger. ISTRO guidelines, mostly the volumes are lesser. So how to contour the level 1 group of lymph nodes? So this yellow contour is the axillary group of level 1 group of lymph nodes, and superiorly is the exit of pectoralis minor. This is the exit of pectoralis minor muscle exit, and this is the boundary from the upper border of this level 1 axillary group of lymph nodes. Laterally, this is the latissimus dorsi, and this, as I told, this is the fat space around where you should contour the line. This is the don't go the outer boundary of the pectoralis major muscle. Then medially, it is the lateral edge of the pectoralis minor muscle. This is the lateral. This is the axillary vessels. This is the lateral boundary. Is the medial boundary is the lateral boundary of pectoralis minor muscle. Posteriorly, the anterior margin of the subscapular. This is the subscapularis muscle. The muscle deep to the scapula is the subscapularis, and the posterior is the anterior margin of the subscapularis. So you can go to down contouring, contour. See, this blue line is the axillary vessels. So this is blue. This color is this is the axillary vessel. You go down, go down, go down, go down. So inferior is the lateral edge of first slice of the So see, when this is the pectoralis minor muscle, this is the pectoralis major muscle. When the pectoralis minor muscle gone and the pectoralis major muscle, only the pectoralis major muscle you see, and fourth rib you see, this is the lower border of the level 1. Then level 2, again same histro-artiology 4 guidelines. You can see this is the again guideline. So what is the upper border? Upper border is the upper border of pectoralis minor. So this is the coracoid process. You can see this is the pectoralis minor muscle. So this is the origin. So you have to contour the pectoralis minor muscle. Then you contour. Then so medially is the medial edge of pectoralis minor muscle. So don't go beyond the pectoralis minor muscle, lateral edge of the pectoralis minor muscle. So here controversy arises when you should contour the pectoralis minor muscle inside your contouring or outside of the pectoralis minor muscle. So if you suppose you have a interpectoral nodes, you have a multiple massive axillary burden, you can include the pectoralis minor muscle, but when there is N0 or no interpectoral nodes in the pre-op and pre-NSCT, don't include the pectoralis minor muscle. But there is a huge, there is a different guidelines. You can use the pectoralis minor muscle inside the axillary group or not group. So this is the thing, anteriorly the posterior margin of pectoralis major, or if you don't include, it is a pectoralis minor. So you contour this blue line, contour. Inferior, the loss of head space between rib and the minor. So if there is, usually this is the head space. So there is no head space here, you stop here for the head space between rib and minor. So this is the thing, how to contour the level 2 group of lymph nodes, then contour on the level 3. So level 3, again, same table, you can go through this and you can either follow the vessel guideline or musculature guideline. So if you see, again, it is a medial root to the pectoralis minor muscle, posterior to the pectoralis major muscle. So superior body, the origin of the pectoralis minor muscle. Laterally is the medial margin of the pectoralis minor muscle. Medially is the first rib and pectoralis minor major muscle junction, clavicle or rib junction or pectoralis junction. Then you go down, contour around the axillary vessels, include contour. Inferior, loss of head space between a rib and major muscle. So if there is, when the space comes down, don't contour further. So there is no head space, no need to contour further. So this is the level 3 group of lymph nodes. Then supraclavicular area. Again, same table, you can go ahead. So you can go ahead. Same guidelines. So supraclav, again, there are two guidelines. The superior is the lower border of cricoid according to the RTUG guideline. So lower border of cricoid, and anteriorly the posterior of the sternocleidomastoid. This is the sternocleidomastoid posterior. Posterior is this is the scalene muscle. This is the yellow structure is the scalene muscle. Posterior boundary is the scalene muscle. Medially, it is the medial edge of carotid. So there are two guidelines. One guideline is telling that you can exclude the carotid, and some guideline is telling that you can include the carotid. So if you include the carotid, the esophageal and trachea thyroid dose may be high. And if you exclude the carotid, it may be this structures may be low. So, and lateral is the medial edge of subclavian vessels. This is the subclavian vessels, and lower edge is the clavicular head. So when the lower edge of when the clavicular head lower edge, that is your lower edge. So this is the subclavian. Then internal mammary group of lymph nodes. If you are contour the internal mammary group of internal nodes, you have to contour the internal mammary vessels and vessels including the artery and vein. So again, the table, you can follow this table. So this first rib, you can contour this first rib, and this is the first rib you can contour. So this first rib, then Then lower border of first rib you can contour. This is the lemon green area. There are two vessels. If you have given the contrast during the treatment simulation, you will be able to see two vessels around this area. You can contour this area. So this is the IMN group of lymph nodes, internal mammary group of lymph nodes. At the cranial border of labor fourth rib, you should stop the contouring of the internal mammary group of lymph nodes. If you take fourth rib below, if you take the below fourth rib as a contour, your cardiac dose definitely going to increase. So don't go beyond fourth rib unless there is any enlarged node below fourth rib. You have to contour. So this is the for the supraclav, internal mammary, and axillary group of lymph nodes. Now, what are the GCP parameters for the MRM? What is the CTV, GTV, CTV, PTV for DVH evaluation? So remember, if you are a primary BCS, you have to go for a CTV, PTV, and DVH for the evaluation. Boost is the KVT, CTV KVT, PTV, and PTV boost, and DVH for evaluation. Chest wall, the very small area is the skin, subcutaneous tissue, rib, and intercostal muscles. So mostly the people tell, the guideline tells you exclude the intercostal muscles and the rib. So this is the CTV chest wall. Then you give 1 centimeter margin. So what is the medial margin? It's the internal thoracic, lateral thoracic artery boundary, and internal thoracic artery boundary. So from here to here, you have to contour, and after that you give 1 centimeter margin. But the DVH is the not to what you are going to evaluate this one. So what do you have to do? You have to go for a 0.5 centimeter from skin and 0.5 centimeter from the chest wall. So this will be your evaluation DVH. Same thing, whole breast, you no need to include the skin or rib or intercostal muscles at all. Only the glandular breast tissue and subcutaneous tissue has to be included. So this is the again various guidelines. You can go through it. So this is the lateral thoracic artery. This is the middle internal thoracic artery. So you can contour this area. No need to contour the skin. No need to include the intercostal muscles and ribs. So then you can give the PTB breast, that is the 1 centimeter margin. Then again deduct 0.5 centimeter skin and 0.5 centimeter from the chest wall. So this will be your PTV evaluation and DVH. If you evaluate this DVH, you will never achieve the things. You have to evaluate a PTV breast DVH. So this will be your contour like this. Then boost is very important again thing. When your BCS is there, you have to contour for the BCS. Breast conservative surgery, you have to contour the breast cavity. Usually 1.5 centimeter from the radial to the cavity. But if you have a extensive DCIS and incomplete excision, you should use 3 centimeter as per the guideline. So this is the cavity. This is the 1.5 centimeter expansion. Let's how to show this guideline. So suppose most of the times we don't know the how to control the boost. So because there is no tumor tissue at all. So most of the, remember, this is called a scar. You can mnemonics, you can scar. Scar meaning you follow the scar. Then C for cavity, clips, clinical finding, A for architecture, and radiology. Radiology, prior imaging from the, you take the advantage of CT, PET, MRI, and mammo. So scar, sometimes you contour the scar, and under the scar, this is the clinical cavity. And if you do proper clinical examination before the starting of the radiation, starting of the surgery, so that you can make a picture on your book, so that clinical examination you can do. So this is the, sometimes most of the times we should encourage our surgeons to put clips, and this is the clips. You can find these clips around the breast, that cavity area. At least if you are not finding, you contour the cavity. And if it is nothing is there, you are not able to do the proper things, you can see the architectural abnormality, you can contour that one. Radiological pictures, if you can see from PET or old MRI or mammogram, old CT, you can overlap and fuse the structure, but it is mostly times it's not fused properly, some erratic issues. So this will be your GTB boost. You give 1.5 centimeter margin, CTB boost, and you exclude the muscles. Sometimes the cavity may attach to the deeper structures or deep structures, but be careful when you're excluding the muscles and intercostal muscles. And then give PTV boost up 1 centimeter margin, and then that is called PTV evaluation 1.5 centimeter from the skin. So this is the things you have to follow. Some changes are there. Ribs are not included CTB in case of chest wall contouring. The dorsal border of lymph node level 1, level 2 is no longer define the depth of the target volumes. Pectoral minor is not more included in the level group of lymph nodes. So exclude the carotid artery from the supraclavicular volume, and IMN should not be included behind the sternoclavicular joint because it causes more dose to the ipsilateral lung. So this is the things you to remember. And IMN that is modified include both the internal mammary veins and internal mammary artery. May dose coverage to the lateral part of the level 1, sometimes also level 2. In patients with a clearly visible glandular breast tissue, it is recommended to include glandular tissue, not necessarily external volume, lateral up to the thoracic vessels. And in conclusion, understand the anatomy properly, follow the guidelines. Vascular guidelines looks better and lesser volume like histo guidelines. Follow clinical findings before, follow imaging, pre-chemo imaging, pre-op imaging, pathological findings, mammograms. That was not a minor things. It is a major things you can understand all things properly. So I'm going to share you the planning how to do and things. So this is the So this is a breast conservation surgery done. This is the BCS case. So what you have to do? You have to so CTV right breast. This is the CTV by whole body by istro. This is the according to the vascular marking whole body RTOG. So this is the 3 overlapping structures. But I follow the istro guideline. Then what you have to do? Then you have to go for the PTV whole breast istro. So after giving after contouring your according to the vessel guideline, so now you can see this lateral thoracic vessel. You can draw a line along these structures, and you just follow this. This is the lateral thoracic artery. You can follow this guideline. This is the lateral boundary, and this is the medial boundary. You can so this is the artery. You can see this artery is very this artery you can follow. You can this so this is the vessel. You can do this vessel. So this vessel you can follow, and this lateral thoracic artery you can follow. You can control this accordingly. The CTV breast and CTV whole breast and PTV whole PTV breast. So this will be your contouring breast contouring, and sometimes where we can do upper border and lower border are also important. We usually take we put a clip 1 centimeter below the opposite breast, and we are contouring the opposite breast. So we contour that clip area to the lower border, and upper border depends upon the whether you are treating a supraclavicular area or not supraclavicular, or just upper border of the clavicle. So this is the things what we do, and then they can again the boost. It depends upon the we do clips. These are the various clips, and this you can see these clips. So these are the various clips deeper when the deeper boundary, and this is the scar. This is the scar. This is so these are the various clips, and this is the boost area. This is the boost area. So you can plan accordingly. Now give to 1.5 centimeter margin, and then you can see these two vessels. This is the you can see these two vessels. These are two vessels which are mostly known. This is the two vessels you can see. These are the internal mammary vessels. So contour at the lower border of first rib. Don't contour behind the clavicle. It causes more long toes. Just contour the beyond the first rib and go down contour till fourth rib. Cranial border of fourth rib. This is the two IMN vessels you can see here. This is the thing what I am going to tell about this guideline, and let's see how to I will show on the planning. So this is the planning. What do you do? Today, till today, I feel the breast planning is the 2D planning is the best. So 2D planning is the best. So this is, if you see the 2D planning here, we did 2D planning here. Remember, 2D planning also looks better, nothing to worry. But sometimes the homogeneity you can better achieve with ARC and IMRT and field technique. So 2D planning, if you see the DBS statistics, so if you see, there are two things, PTV DBH ISTRO and PTV DBH whole body ISTRO guideline. And so if you see the right long, we have kept is a even 2D also, the dose is going is under 28, 20 is 14% only. So again, we have to see the IMN, how it is usually 90-95%, how it is. So we have not included right IMN here for the treatment. So we are not including this. So if you see the CTV is. So mostly try to get the less long dose with 2D plan. And if you want to go see the VMAT plan, So this is the BMAT plan we can see here, but it is a fuller, don't go for fuller, partial arc is better. Until medial partial arc and lateral partial arc. And if you go for the deviation statistics, if you so if you see 20 grade 17% long, but when you are going to treat, always see the low dose volume also, it is 29%, and the 5 gray volume is also less than percent. So you have to follow properly, see the 5 gray volume, 5 gray volume, how it looks, how it is distributed in the area. So if you see this 5 gray volume is not, let's confine to the your part, same breast only, and not going to the heart area and opposite to lung. So this is the 5 gray volume. Always see, look for the 5 gray volume or 10 gray volume. 10 gray volume, you can see the 10 gray volume also. So this is a 10 gray volume. So keep it, don't spread your 5 gray, 10 gray volumes above on the heart or opposite lung. Keep it minimum, and more 5 gray volume should be below 50%, and 10 gray volume around 30%. Usually we, but better to prevent pneumonitis and all things. If you go for the RTOG for the BMAT plan, RTOG volume, you can see the deviation statistics. If you see the right lung, you can see. So if you see 20 gray volume, it is a 21 gray. So more RTOG is more volumes than long. So definitely long doses incoming more. So this is the 20, but in if you compare with the two plans, and oh, sure. So another structure I want going to tell you about is the various things you can see. This is the, again, we have contoured axilla level 1 and level 2, level 3 here. You can see here. So this is a contour we can do here, axilla level 1, level 2, level 3, according to the vascular guidelines. We do give contrast all simulation plannings, and we just contour level 1 and level 2 and level 3 guidelines. Level 3 contourings. And if you see, this is the istro RTOG, again PTV chest wall istro, and so we have did the planning with RTOG plannings. So this is the chest wall contouring. I still prefer go to it 2D plan rather than arc plan. So if you want to, if you have urge to plan the BMAT, please keep the minimum so if you see the I want to go to show you RTOG lung. So right lung, if you see the 20 is getting 20 gray with BMAT, but istro, if you see the istro guideline contouring and Hadito, how much it is coming. So right lung is coming So it is 14 gray only. So if you go to the RTOG volume, definitely it is the volume is more and the long dose will be more. If you go for the ISTRO guideline, the long dose will be less. So this is the thing why I want to tell you. And so still we prefer going by tangential fields, and but tangential fields unnecessary, some normal structures also get dose, and same time the long doses will be slightly high, and you can see the right long dose, you can see it is a 24 gray. So that slightly with a 3D maybe slightly long dose will be more, but low dose volumes will be less definitely. So low dose volumes you can see. So low dose almost slightly less. So don't spread your low dose volumes in the other side of the lung and heart areas. So this is the all things I want to tell you about this today. And if you are planning in BHIM fast forward plannings, you can follow the strict guide. This is we have a plan for the fast forward guideline, and this is the things you have to see. PTV whole breast, DVH. So these things we deducted the minus. So if you see this so if you go to this, still we planned with 3D CRT and DVH. If you see, you go to the statistics, long right, you can see this is the 20 gray volume. If you can see, this is 8.24 gray because the prescription range is 26 gray only. And if you see PTV DVH whole breast, if you because the prescription range is 26 gray, so only 57% coverage. Oh, sorry. So we have strictly followed the guideline of the DVH protocol. You can see that is a 90% coverage. This is the coverage. You can go through this articles and fast forward protocols. You will have the good idea. And this is the main thing. Still, I prefer 3Ds sometimes. But if you are going for the VMAT and all things, please keep your doses minimum 5 gray volumes around 50% and 10 gray volume around 30%, and 2 gray 20 gray volume around 20%, so that it will be better for the patient and not much side effects. Thank you very much. This is all about my presentation, and if you have any doubts, you can just ask me. And
hello, will you please show again the controlling of lymph nodes?
You want to see the lymph nodes?
Yeah.
Okay. So you want to throw presentation or planning?
Planning only, planning.
Planning, the planning system? Yeah. Just give me 2 minutes. Sir, visibility is?
Yes, please.
Okay. So So if you want to do the contouring of the axilla, so this is the pectoralis major muscle and minor muscle. So you have to see the coracoid process here, where the pectoralis minor muscle originates. This is the origin of the pectoralis minor muscle. You should this is the area where we contour post lateral to the pectoralis major pectoralis minor muscle is the level 1. Then level 2 is the posterior to the pectoralis minor muscle. Again, origin from the same pectoralis minor muscle and go down when the space between the intercostal muscles and head space, the muscles and pectoralis minor head space decreases. Don't stop there. Same thing, axilla 3, and you can contour from the this area to and go down, and where the head space decreases and the pectoralis minor muscle, you can decrease the you can control this axillary guidelines. If you want to see the SCF, you can control this till this is the till post cricoid area or inferior till the lower border of the cricoid cartilage, behind the sternocleidomastoid, anterior to the scalene muscle, and control the all head space around the vessels. Istro, you can exclude the carotid artery. RTOG, you are falling include the carotid artery.
Okay. Thank you, sir. So nice of you. It's much clear now.
Any other thing you can?
Yes, sir. I have a question, sir.
Yes, sir. Hi.
Yeah, hi, sir. Yeah, so just one clarity.
Please tell me, sir.
In for chest wall contouring, you mentioned it needs not to be included. So, is it as per ISRO guidelines, or is there any change?
And then most of the guidelines they told don't include the rib and intercostal muscles. But sometimes chest wall is so thin, what to exclude and what to include, we don't know. And when sometimes the lesions are deeply seated and deep margin is very less, 0.1 mm or 0.5 mm, better to include that area rather than leaving this place. So this is the things what I going to better to exclude ribs.
Okay, but because RTOG guidelines mention that posteriorly, specifically they have mentioned need to include ribs and intercostal muscles.
See, RTOG,
so
we don't follow, most of the people don't follow RTOG. Mostly people follow URTs because the volumes are more.
Okay. Yeah.
And no such recurrence. But remember, it is not guideline. You have to put your all things. Where is the tumor located? How much distance between the deep muscles and the tumor? Everything you have to take in the account accordingly. You may not include below 2 cm below the tumor and above the 2 cm above the tumor, but tumor area you better to include. So it is your method of doing. So better to exclude the ribs, but remember, always follow the old images before NST, NRT, NST.
Okay, thank you, sir.
So why? Was Dr. Ayush said why ribs intercostal muscles. So ribs you can exclude according to the. It is not a site of recurrence, but intercostal muscles depends upon you. Okay, scar boost should be included in every case after MRM. We don't use scar boost unless there is some close margin or positive margin or something. We cannot do that, and if there is very much skin infiltration. Indication of periodic in axilla and post-op. Post-op MRM, properly axilla dissection, we don't treat axilla at all. And if there is a sentinel lymph node biopsy done, a single node positivity, you can go for the axilla treatment. Mostly SCF indications, mostly large volume tumor, more than T3, and more than 4 nodes positives as previously. Now we are treating with single node and 2 nodes as a positive. We go for the SCF irradiation. Even adequate axillary dissection, even N3 ENE positivity, we don't treat axilla. If there is a gross residual or adherent to the subclavian vessels, any gross node is there left behind, you can go for the axillary area radiation. Somebody has asked you what is the 2D planning is better or the conformal. If you can control your the 5 gray volume, 10 gray volume, 20 gray volume adequately in the conformal planning like IMRT or BMRT, better to go for the better homogeneity in the contouring planning. But if you are not, you people are the physicist is not so sure about the decrease in the dose to the lung, better go for the 2D planning. So PTV evaluation and PTV disease, I think they are two synonyms. So what you do after giving the PTV 1 centimeter margin, PTV DVH is the 0.5 centimeter from the skin, 0.5 centimeter from the chest wall. That will be your PTV DVH or PTV evaluation. So that is the thing we have to evaluate, not the exact PTV. Anybody has any questions? So if there is no questions, tell me, sir.
Sir, is there any difference in PTV margin if we are planning by 3D CRT technique or if we are planning with IMRT technique?
No, why? So, your margins and everything should be same. But when you are giving PTV margin and everything, if you are planning with BMAT and IMRT, you should give plus. And really, with 1 centimeter plus we give, or sometime if 3D, at least 1 centimeter, 1.5 centimeter beyond the chest wall or BCS we have to give.
So, sir, we should if we are cropping 5 mm from skin, so according to EORT, ISTRO guideline, RTO says 3 mm. So is EORTC decreasing too much of volume?
So RTOG, we don't follow RTOG actually. Even unnecessary decrease the dose to the increasing dose to the skin. And remember one thing, you have to prevent the skin reactions. Like that, you can accept the skin dose to the head and neck area 110%. You can accept.
Yes, sir.
But breast, either MRM or don't go beyond 105.
Yeah.
Ask your species to decrease the 105 volume as much as possible. Even 100% volume, if you are getting homogeneous, then it will be most fine. You will not get the skin reaction. And another thing is, if you are want to, if some people use bolos and not bolos, invariably I use bolos when there is a given, we don't know about the skin things, and even there is CT has already received and the skin positivity or margin is less, I use half of the radiation fraction. I use bolus, 0.5 centimeter bolus works, normal bolus, but half of fraction I don't use bolus. So there is a lot of controversy about the using of the bolus, but I invariably use skin row in NACT lesion, NACT received, those who received NACT or NACT. So don't worry, some people have asked about the presentations and recordings. Within few days, today I'm going to share the presentation, and within few days I'm going to share the recordings. And you can go through the YouTube, you will find the all recordings. So if there is no questions, if you still I have a time, you can ask questions. If you want questions, any I will answer, or we will stop here.
Sir, do you follow RADCOM guidelines for supraclavicular? Because they take posterior lateral SCF also. They take lateral SCF also.
No.
SCF
No, we don't follow actually. So another thing I am going to tell about when you are planning for food, you just put gantry outwards, either 20-degree outwards, so that dose to the esophagus, dose to the post-cricket area, dose to the opposite lungs will decrease. And when you are planning for the VMAT also, give a constant to esophagus to prevent dysphagia.
Sir, one more thing, in conventional planning, in 2D planning, they used to rotate the head to the opposite side. Now
better to rotate. If there is a very simple thing, from simple thing we can prevent the dose to the thyroid, you can dose to the esophagus, you can decrease the dose to the your central structures. It is good only to rotate the head opposite side.
So usually, sir, we are giving PRV esophagus.
Okay.
To prevent dose for planning purposes, we are giving PRV esophagus to prevent dose to esophagus.
Okay.
Because what we guidelines, they are not rotating head; they are keeping the head straight in whatever guidelines like TC or.
I have a special in our hospital. I have a special breast outfit is there. It can prevent the. We can put the breast outfit so that it is the patient cannot move the head and left right during the radiation. So why people don't prefer to put the head opposite side? Because if you are not proper emulsion device for the head part, every time it changes.
Okay, thank you, sir. I hope I'm not troubling you.
Yeah, no problem. You just ask anytime, any questions you can come ask WhatsApp.
Because these are very controversial things, because the breast is, I think, one of the most controversial side where there are so many guidelines and you just don't know what to follow, which guidelines we should follow, because at the end we have to follow all the patients.
Go for the ISPRO guideline.
Okay.
Can you do 2D?
Because we can. Because sir, I think we cannot do that. One patient we plan by this guideline, another patient by this guideline. We won't be having a universal data or data. For that purpose, also we should plan by same guidelines to all the patients rather than doing different guidelines in different patients.
Yeah. But in our hospital we regularly follow fast forward that followed ISPRO guideline. So unnecessarily giving RTOG guideline, you are increasing dose to the cardiac, dose to the lung. Yeah. So somebody asked, somebody asked, can you do the 2D plans without breastboards? Yeah, sometimes we do, but see the positioning, and that position should not be changed during the normal simulation. Sometimes we do, but we have a study about with or without a breastboard, not much change. But I prefer still, if I have breastboard, I will prefer breastboard only. Hope you have all enjoyed my talk. Anything, anytime you can WhatsApp me or call me. It is a pleasure to answer your questions. If no questions, I will leave, close the session. Clarinet people, please. I'm leaving the session. Any comments from your side?
No, sir. We haven't received any questions from our partner.
So thank you very much, madam, for giving the platform. And we are just
thank you so much, sir, for extending us the opportunity to host you and host the session. And I hope you had a seamless experience.
Okay. Please send the recordings and registration.
Yeah, sure, sir. Sure.
Vimeo recording. That are 2 types of recording you are sent.
Sure, sir. Definitely, I will inform to my team, sir.
Thank you, ma'am. Thank you.
Okay. And with all due permission, I'm closing the session today and looking forward to hosting you again. Thank you so much and good night.